Good. Well, good morning. I'm going to start. I think we have about 12 people, and I know there's probably a few more who will join as we begin, but I thought we'd maybe get started. Just a little housekeeping. I am recording this stakeholder meeting and committee meeting so we just have reference. I believe I turned on the captions, and if you need to turn the captions on, you should be able to do that. And then if you don't want the captions, I think you can turn them off. And usually we have a pretty small group and we know each other, but I think we have some new people, which I think is really exciting. So rather than going around and pinging everyone, what I'm going to do is if you want to introduce yourself, I'm just going to have you raise your hand and kind of just give you just a couple minutes minutes to introduce yourself. For those who don't know me, my name is Casey Wardle. I am the benefit supervisor for the CIH, or the Complementary Integrative Health services, as well as I helped with the expansion of the waiver last year. So we're kind of moving from the expansion of the waiver to really looking at how do we make these services as accessible and as useful for providers as we can and for members. So that's what we're here to do today. If anyone wants to introduce themselves, feel free to. I do want to apologize. I think you might have heard I do have a new puppy, and due to the raining, we didn't get him exercised. So if you hear some barking or wrestling, that's what that is. So, I don't see any hands raised. So if you guys want to start raising hands, if you want to introduce yourself, I'm not sure if Shanda. There's Heather. I'm not sure if Shanda's going to join us today. I know she had other previously scheduled. She's in the midst of her important, amazing fundraising and dinner. So if she doesn't join us, I think Heather will be here for Shanda. So instead of having her lead the introductions, just if you want to raise your hand, otherwise we'll get started.
Casey, I'll introduce myself. I'm Brian Bain from Developmental Pathways, one of our program managers.
Welcome, Brian. Thank you.
I'm Greg Shim, and I'm an acupuncturist here in Castle Rock, and looking forward to being part of this program in Medicaid.
Welcome, Greg. Amy and Riley.
Hello, everyone. This is Riley and Amy with New Ability. We're a CIH provider of massage, acupuncture, and chiropractic here in Northern Denver.
And if anyone has not gone over and visited their facility, it's a pretty remarkable facility. They do some great exercises and all sorts of great interactive therapies or adaptive therapies.
Yes, thank you, Casey. Thanks.
And Greg Shim is an acupuncturist, Primalized Health. He's been an acupuncturist, and we connected through the Acupuncture Association. So I'm really excited that you can join us too. So, and being part in Castle Rock, which I think there's just a lot of people who need your services. So.
I'll introduce myself, Casey. I'm Andre LaRue. I'm the executive director for the Colorado Chiropractic Association, and just happy to do whatever we can to help get the word out about chiropractic and to Medicaid patients and get providers enrolled.
Yes.
Stuff, right?
Sarah, did you raise your hand?
I did. So I'm Sarah Purdy. I'm a clinical care manager at Craig Hospital. Obviously, we send a lot of people to this program, and I've been on this committee for a long time, and I worked at the single entry point before coming to Craig. So,
and always thank you for your input. Okay. Am I missing any hand raised? If I'm not, we always make this committee. I think what's unique about this is we're very collaborative and interactive. So if you have a comment on anything, we're going to.
You muted yourself, Casey.
Yeah. If you haven't introduced, Lisa, do you want to introduce yourself?
Sure. I'm Lisa Bullis. I'm an acupuncturist on the waiver, and I've been on this committee since before it was a committee. So yeah, it's so exciting to see all the expansion work you've done, Casey. Thank you.
We're getting there. So. Now we just got to get members to know about these services and really connect with providers. I think that's the next step. All right. So, Heather.
Hi, I'm Heather, and this is Carrie, and we're with the Chanda Center for Health.
Great. Thank you.
Integrative therapies, acupuncture, massage, and chiropractic services for the CIH waiver.
And for those who don't know Carrie, we're actually going to talk about the care plan today. So for anything care plan related, she is our expert on that. So she may have some insights. Okay, great. And as I was saying, this is a fairly collaborative. We are going to talk about some interesting changes that have come up in the next, or possible changes that we can make to this waiver. So kind of unexpected but exciting. And then we'll I'll first give you an update. So if you do want to make a comment, be collaborative, please feel free to just introduce yourself before you speak, so we know who you are. And do want to remind that this is being recorded, so please try not to use public private health information, personal health information, just so we can distribute this appropriately, unless you so choose to, and it's your own. Okay. And I think I saw my supervisor, Karen Stewart, just came on too. She's helping. She's working on all this very much, and has been such a great team member and collaborative support on this.
Morning, everybody.
All right. So I think since Shanda's not here, I do want to introduce, just kind of, we tend to start these again with the introductions, and then give an option for people to have some public comment, just to give them kind of any updates or any places that have changed or since we last meet. So if anyone has any comments, feel free to raise your hand. All right. Well, there'll be another option after we go through this. And again, please feel free to just comment as we go through these too. So I wanted to give an update. As we know, we kind of keep on the agenda, which we're going to, on the invite, I think, which most people are here. And if you aren't on the invite, we're going to try to get this Google Notes, that we kind of keep track of all the meetings we've had before and kind of where we're at. Our last meeting was on February 9th, and these were our key performance indicators at that point. Since that time, we haven't had we're not able to we're having some changes to our updating and our data reporting. So our CIH services still are showing about the same, but there's still the data. So we unfortunately can't update that. What we can update, which is really exciting, is that we've moved from, last time we talked about 6 providers, we now have 11. And I think we identified an issue with our Find a Provider tool, with the HCPA Find a Provider tool, that when someone had enrolled, the case managers or us or members weren't able to find acupuncturist, chiropractor, massage therapists from that big provider Find a Doctor tool. That is currently being updated with ARPA funds, but it may be like 6 months to a year till that actually rolls out with a better search function and everything. And so what we're going to do in addition to, and in the meanwhile, is Jen Larson, who is our webpage coordinator, has created this great list and searchable list of our providers. You can search it by name, so let's say I want to find someone in Grand Junction. You can just type in Grand and, Trinity Massage, or if you want to type in Wheat Ridge. Oops, if you know how to spell. You can type in Wheat Ridge. You can search by counties. But if providers or case managers see any mistakes on this, please just ping me and let me know. But I think this should be a really exciting addition and process to helping case managers and members find providers, which I think will be really exciting. And as you can see, we are starting to get things. And as you're saying, we're starting to get a little bit more around the state. So we had Grand Junction, Jeffco. Hi, Maya. Jeffco Jefferson, Boulder, we still, and Colorado Springs, we're almost got our chiropractor, but we do have Greg, who's here from, where's Greg? We'll find him in Castle Rock. And so slowly getting there. I think we have about, going back to our key performance indicators, I think we have about 7 more providers in the enrollment process right now. I really want to thank Shanda's team, especially Haley. They went to the Massage Therapist Association last week and put out a memo that we needed. And we got about 3 or 4 massage therapists, even in Colorado Springs and Fort Collins, expressing interest. So there's a lot there. There's good movement there. And I do think one thing we are working on to see how, and we'll talk about it later, how we can align some of the other massage therapists who are already enrolled in SLS, supported living services, so other waivers, and to see if they can just move over and accept CIH members as well. So those are the things in progress. Still taking about 6 weeks for enrollment, maybe up to 12. I think some of the providers here can give us a better idea to that. And yeah, again, same as we were in February, unfortunately, this time for providers to find members is taking a fair amount of time, and a place Karen and I are very aware of, and we're going to work with case management, the case management team specifically, and case management agencies to support them in the conversations with members, and also identify any places where we might be missing on that waiver transfer like we talked last time. We have worked with El Paso and Colorado Springs, and we're working with Grand Junction, but I'm guessing we need more of that. So any comments? I was pretty fast on the update. I think going back from our notes last time, we really did talk about those county diagrams and gaps of knowledge. And we haven't made much progress on that, but it's on our radar, and a place where we're definitely hoping this summer and the fall to get going. All right. Anyone have any comments or thoughts on that information?
Casey, it's Lisa. This would be great information for us as current providers to have access to in like a printout or something like that in the clinic, because we have people who come from so far away, and sometimes the distance they travel is so much that they can't come in frequently or regularly. So if we had access to this and we're able to pass this on directly to our participants, we might be able to help get people dispersed to these other places.
Yeah, and that's what's so great. I think I hear that, Lisa. So if you could, this is on the CIH webpage. So if you go, I'll show you how to get there. So if you go to the CIH webpage, it used to say here, CIH providers and list like the 5 ones. Now there's a CIH provider list page, which will take you to that search. And you can just print from there, whatever. So say you do a search of counties, you can print from there. If you print landscape, they'll all be there. So we made sure that you could print. And you can either save it as a PDF or print it from that function.
That's great. Heather, maybe we can print that out and have it for all the providers to be aware of at the clinic.
That's a good idea.
I think I saw a comment come up. Yes, Denise. I have literally spent 10 hours trying to find providers in Fort Collins. We're driving up there, meeting with people, calling people, maybe more than that when you think about it. So we haven't, there's one that's still enrolling in Longmont. And what we're trying to do is, again, look at those the waiver providers on SLS supported living services who are in Fort Collins, and really trying to get them to offer these services. So that's our new strategy. If anyone in Fort Collins knows of anyone, I think Andrea, this might be a place where the chiropractors, like, we really want to target Fort Collins specifically And now that I have the memo for massage therapists, that's an easy email we can get out to everyone in Fort Collins. So
That's perfect. I was just going to ask you that, Casey, if you, since our last meeting, had identified, any areas where we could focus communication. So I'll definitely talk to Erica, our membership and marketing person, to see if we can get a few emails out to to our docs in Fort Collins in that area specifically. Do you have any other areas that you know of patients that are?
Colorado Springs, Pueblo is our main area that we're still, we have some people providers enrolling and coming on there, but I think there's such a need in that area. We could have multiple providers.
Okay.
So, yep, we'll work together to get that done.
Okay, perfect.
And I'll reach out to North Chiropractic. I haven't reached out to them, Kelly. So I have it. I pulled it up and looking at it now. So maybe we'll work to do that. Yes, Greg.
Do you need a chiropractor in Castle Rock?
We would love a chiropractor in Castle Rock.
I have a guy in mind that I'll go talk to him after this.
Great.
Okay.
Thanks. Okay. So that's our update on provider enrollment and support. I do envision eventually, once we get the whole group, I think I've talked with some of the other providers of really looking at a great community of practice. We just have enrolled such great providers, and with such a wealth of knowledge that I think even just having a touch in, once a year, a couple times a year would be really good. So that is sort of that support part of the agenda I put on there, but that's where we're at. That's a future. And if you want to connect, I would, now that we have this list and this, please, if you want to connect between each other or have questions, I think that I will always be encouraged and wonderful. Okay. So I think the other part, which I didn't put on the agenda, but will only take 1 second, is this mission. And I think everyone's aware of this, the pilot study, or if you're not aware, there's a pilot study associated with this waiver and the CIH services. We've contracted with a company called Mission Analytics, and this is a study not only to find the qualitative, our members liking the support, feeling better, really benefiting, but then there's also a quantitative part where they're actually looking at claims data over 2 or 3 years and looking for cost savings, which is really unique and needed just to grow these services across the nation, so more people can access these, cost-effective and really person-centered services that we provide. So we do have a 30, and Ellie just updated that they almost have a 30% response rate on the qualitative part, and we'll continue the calls. The next meeting, she'll probably give as she has in some of these other meetings, kind of give an update on the cost, on what if there are new findings. Since we do have more people receiving these services, we're hoping to be able to get statistically relevant data, which is what we haven't had up until now. So let's see. I don't know if we want to have this. So next up on the agenda, I wanted to get, maybe take 5-10 minutes. I know there's some case managers and providers, to really talk about if there's, understand how some case manager agencies are doing with meeting with members, and if members are interested in these services, or if it's just we don't have enough providers and the providers weren't listed. But I'd be curious why more members aren't kind of utilizing these services. Does anyone have any thoughts?
Hi, this is Kelly in Larimer County, and I'm a case manager. I have a couple of clients who could qualify for this, but they are sort of nervous about it. And then everything they have on their current plan is working for them. And then just, the fear of having to travel so far. A lot of them can't be in a vehicle for that long. So hopefully if we get someone closer, then they might be interested.
Yeah. And I think that fear and that they're happy with their current services is something where we need. Thank you for bringing that up, Kelly. And I think spending more time with members and really working at that waiver, helping and I know Larimer County said this, but you don't really have a hard time transferring between waivers. Other case management agencies have really had concerns with transfer between waivers and if the members are going to lose their services. So we have done some test pilots and some case studies that we're not officially through. I think Greg, a few people are hopefully going to help with that for Colorado Springs. So once we get a provider in Larimer County, even if we can have just these little case studies of this is what the process was for me, these were the things, like the members' voices, I think hopefully that will help that. So thank you, Kelly, that's great. Does Jefferson County or anyone else having challenges between waiver transitions or members being concerned with liking their services or?
This is Alicia with Jeffco. We don't have any problems. We've had some interest in it, but they have just kind of been borderline. So a lot of individuals are just kind of questioning actually making that jump and just the change of it not being not a lot of people deal well with change. So I think that when they're comfortable in their waiver, getting the services, that they kind of going, hey, we encourage you to make this change. It's just kind of formally talking to them initially, and they haven't actually made the jump yet. So wouldn't say we have any issues quite yet. The providers, adding additional providers is always wonderful, but them actually making the decision is kind of where we're at with some of them.
Is there anything we can support case managers in that decision to help with members or that conversation that you can think of?
Not that I can think of. I spoke with the team yesterday. Most individuals after COVID, just kind of getting out of the house is another step for these individuals. So I think that's kind of the barrier they're trying to work through. And now that the public health emergency is ending, and we're going to see more people out and about, and case managers are going to have to go back into the field a little more frequently, actually 100% in the field again. I think people will become a little more helpful there, and feeling comfortable with just making the change and knowing that it will be okay and it is a positive change because there's additional services that go along with it.
That's great feedback. Thanks, Alicia. Heather.
Hi, this is Carrie. So some of the challenges that I'm running into is just worried that maybe some of the case managers still aren't fully educated on what is eligible for the waiver. I've had a couple people recently with spinal, that would qualify for a non-traumatic SCI, and the case managers said no, and actually put them on the EBD waiver. And now I'm having to fight to transition. So they spent all this time, going through the waiver process just to say, no, their diagnosis didn't qualify when it actually does. Then put them on the EBD waiver. And now I'm having to go through, which takes a long time just to get them on one waiver. Now we've got to go through the whole process of fighting that. Yes, their, birth defect, their issue since birth, it does qualify as a non-traumatic SCI, and we're having to now transition them. And this has been going on. I mean, a couple of these people that I've been trying to enroll have been trying to enroll since the fall. I mean, this is going back to October. I mean, it's just taking so long. I've got another woman who's had gone through and gotten her diagnosis eligibility, but she's in the financial part. And the case manager said it could take up to 5 months. And it's just, I just don't understand why it's taking that long. And so same thing, she's been somebody I've been working on since the fall to get transitioned onto the waiver, and she's, it's May and she's still not on it. I've had issues with Larimer County, trying to call Larimer County. I can't talk to a live human being, nor can the participant. You call and nobody answers the phone, so you leave a message. I've left multiple messages, so has the participant. This has been going on since, looking at my notes, since February, and neither of us have gotten a call back. So we can't even start the enrollment process for this person because nobody ever answers the phone and nobody calls back. So it just gets frustrating with some of these folks of how long this process is taking to get them switched onto a waiver or onto the waiver. So I don't know what else we can do, but it just seems to be taking an unusually long time for some folks.
Yeah. Kelly just offered, her number and her email for Larimer County. Thank you. And
Okay.
Alicia too. I think really utilize this team here, Heather and Riley. Our case managers are over, so have so much going on. We're making so many system changes that I think I just think sometimes helping us using this to facilitate and connect just may be an easier way to do that. At least for the time being. Again, I think within a year, we're going to go through some of these things within a year. So these things should really be evened out. Maybe 2 years. You might be an optimistic. It's just, there's just so many. I don't know if that echoes what Alicia and Kelly are, but that's what I'm seeing. And I've said that don't, I have the time. If you have, I can help. And I just know all the case managers, supervisors, they're as willing and able to help as they can. So it might take, once you connect with us, it may take a moment, but it will, but at least it's then on the radar. Unfortunately, with the financial part, there's not much. Yeah, exactly. But there's not much we can do other than, we may be able to talk with the county techs and there may be some confusion with the CIH waiver part there in individual counties. So we just need to make sure. We've been trying to, send out as many memos and little emails, but maybe we need to do even more consistency. So I'll write that down. I know we've talked about that. We've done some. It doesn't seem to quite be enough, but the financial process definitely is taking some time.
Okay.
Again, if it's a long time, sometimes we can help. At least we can investigate where it's at. So let us know. What was the other one there? Third, case manager. Oh, and the eligibility part. We need to. That's a great. Thank you, bring. I thought we'll try to get that even more clarified on the non-traumatic. So thank you.
Okay. Yeah, I think just that education, because I totally understand. I mean, the case managers, I know they're just, they're understaffed and overloaded with cases, and so I try to be patient and give them the benefit of the doubt because I know it's a lot, is out of their hands and stuff. But it's just a matter of I feel like still maybe some more education for them just so they really understand, because we are just finding still that, a lot of them are putting people on EBD when they really do qualify for the CIH. And so that's just, but I appreciate everything they do. And I know, like I said, some of that stuff is out of their hands with how fast the process moves. So,
but I think bringing it up. Yeah. Thank you, Greg. Yep. Greg.
Oh, sorry. So I'm brand new to all this. I don't know how any of this works. I responded to an email for a new patient May 1st and haven't received anything back. So it sounds like I just need to keep waiting. Correct?
Yeah, I was gonna give it 10 days and follow back up. So thank you for updating, and I will follow up.
Perfect.
Thanks for that update. I was curious. And Lisa, I think this is great. Lisa's point is for participants not wanting to leave their home they are able to provide in-home services. And Alicia asked an evergreen. And Lisa, you feel free to answer on the chat, but I also want to highlight, we are also enrolling an evergreen provider for massage therapy and acupuncture right now. They're very close. They're on the list. And then also we have 2 more Jefferson County in-home massage therapists too. So maybe I need to add that on the list. Okay. Sorry. Any of the case managers have any more comments on, or should we move? I know that it's probably not. Thank you for. Wish we had better answers for these challenges. We're going to work through them. So, any more comments or ideas on how to keep working through this?
Casey, I have something.
Yes, Riley.
So as we've been trying to also work through the obstacles of just case manager responses and the knowledge that they have, I've been trying to reach out with some managers to invite some case managers into our facility, like show them what we do, the importance of these services. And unfortunately run into the same obstacle of not getting a lot of responses, but that's been an idea that we've been really trying to implement of just, case managers could potentially have better resources and recommendations when they've seen the facilities and the benefits firsthand. So that's something that we've been trying to approach, but have ran into the wall of also getting responses to get that started.
I just think that's such a great idea. Let's connect. And Alicia or Kelly or other case managers on here, if that seems something we could set up, let me know and connect with me. And I am going to set some office hours and reach out back to case. Hearing this, that is the first thing I'm definitely doing and had already planned on doing, is reaching out to individual case manager agencies. Would this be something like, if we do an office hours, case managers, would this be something that if we invited providers to come to, that was sort of my idea, would that be useful and something you think case managers would want to come to? Or is that just not the time right now?
I would say, this is Alicia again from Jefferson County. I would say probably if you can get it in before July 5th, the assessment tool, that would be great. If not, I would probably wait until fall, but I absolutely love the idea.
Okay. Good point. Thank you. Thank goodness we now have till July 5th, right?
Yes.
Yeah, Alicia, I would love to connect with you because we work with Jeffco mainly next to Rocky Mountain Human Services. So
Awesome. Yeah.
I'll follow up with a connection.
Perfect.
Great. All right. So that's the very practical stuff. I'm going to move on to the unit cap removal and the care plan discussion, because I think this is kind of, hopefully will remove some possible obstacles that are happening with the care and case plan management. Hopefully, again, by giving too much leniences, we're not opening up things too much, but I don't think I've made the announcement. There has been our leadership, even though there wasn't a budget approval, gave the okay to remove the unit cap, the individual unit cap for CIH services. So what that means is now members will be able to receive the 408. So basically 2 hours a week of therapy will still be available. But there will not be any limitations on if they're massage and they need 90 minutes, they can do that, or if they want 30 minutes of acupuncture and 60 minutes of massage, there shouldn't be any problem. Again, this could be some challenges because it moves it much more into being member and provider and case manager directed. So it really comes down to the providers, the case managers identifying a need, which if they're on this support, if they're on this waiver, the need has been identified. And then the providers really working with the member to understand, like, hey, this is what we're trying to work on. This is the need, and recommend within those 400 units what actually is best for the member. Yes, Greg.
So we also have a massage therapist here who's part of this program. So that means when somebody comes in, they can get all of it at once. Is that correct?
Yep. And they could even get, so whatever is best for them. Because I think as we all know, one of the big challenges for members is the travel time. So I think anytime we can cut down on travel and transportation and still meet the needs of the member, that would be ideal. Yep. So there's no limits on that. So it does open up things a little bit, and it also hopefully won't cause too much, jockeying for services. What originally these services were intended to be coordinated by a medical director. That didn't make, there wasn't an MD who was able to do that. So then we went to just like kind of the case managers and the provider doing a care plan and recommending those services. But really we want to we're moving towards participant directed. So where the member chooses what they need, if possible, with the support of the case manager and the recommendation of the provider and then communication before those. And so going just to have this 408 unit, hopefully will just, case managers can just know like, hey, if the provider really recommends this is what the member wants, we can do that. There still will be separate, so chiropractors will have a separate billing unit, massage will have a super prior authorization, and acupuncturists will have a prior authorization. So that's currently where there may be a little bit more work from the case manager, but hopefully we're able to cut down on the paperwork with this second opportunity we have with this case management redesign, which is one of these things that is mandatory. It's been mandated by the federal government. We talked about it a little bit last time. Part of this comes rule revision. And so we're going to do we're proposing a fairly extensive rule revision where we're separating, again, this idea where originally it was supposed to be a complementary integrative health service together, but reality, acupuncturists are separate. We want acupuncturists to be able to recommend acupuncture, chiropractor to recommend chiropractor, massage therapy. We don't want to cross-recommend those. So to do that, we're separating it out. We're proposing to eliminate the care plan and then still have CIH services have that definition. It's going to be moved into a different section, the full definition section. And so that's these red lines are that, and then this is the unit. The other part is we're aligning the provider regulations. When this was first written, there was a bunch of provider regulations put in there. These are all things that should be given under when the provider enrolls and they agree to follow provider rules. We're just aligning those so acupuncturists, chiropractors don't have to follow any other unique rules. So that should be easier to follow altogether. Kind of what I've been recommending and telling providers anyways, that's what they need to do, that this stuff is no longer going to be looked at or mandated in rules. It's important. You're going to still have to have your fire and state, follow your federal, state, local government rules. Make sure you don't have, keep a clean clinic. Those are things that are necessary under a provider's license, as well as take really good note, have their sub notes. So those are part of things within that a provider should be doing under their license already. And then here is proposing. If people have don't want, they just love the care plan and want to keep it, we can have a discussion. But what I'm really proposing is to move to where the complementary integrate. This will, in the chiropractor section, this will say chiropractor providers shall. In the acupuncture section, it'll say acupuncture providers shall. And what we're just proposing to keep is that they're going to recommend the appropriate modality, scope, duration of the complementary health service within the established lists, which is that 408, and recommend only services that are necessary and appropriate. And then it's just between the member and the case manager then to kind of decide ultimately what fits in that PAR and what they're going to put in that prior authorization. Much like what already goes on with counseling services and art and therapy and movement. So we're really trying to align the recommendations and the process for case managers to be the same between all professional licensed services. So they're requiring a license and then making a recommendation based on what they see from the members, and then the participant directed members and case managers from their participant care support plan will then do the prior authorization there. So hopefully this is, okay. I'm open up to any thoughts or recommendations. I know this is kind of big change. And when we had this opportunity with the case management redesign, and that is really stressed to try to align processes between services, just for ease between case managers, so there's not a lot of extra paperwork. This is where we've landed. So, thoughts? Yes, Carrie.
Yeah, so I guess I just have a question. Will we, from my end, will I be so does that mean I won't have to submit anything anymore now? It'll just be automatic and just contact case managers for PARs, or?
Our recommendation is keep the same paperwork you have. It's
Okay.
just not going to be authorized. It's just not going to. So each case management agent, Rocky Mountain is definitely going to want to have some sort of, we've had this discussion, you were on those discussions. Rocky Mountain's still going to want to have a paper so that triggers their process. You're still going to need to do that paper. It's
Okay.
just not going to necessarily have to be department approved. It's going to be whatever works best for you and the agency you're working with.
Okay, perfect. So basically just kind of my care plan now, but instead of separating out how many units they want for each of the modalities, and just write 408 units and just, and then
Well, no, you're still going to have to separate out which one's and that's where it's not going to, because they're still on the prior authorization themselves. We're hoping that the providers are going to guide the members, because that was Shanda's issue. That problem is that the members and the case managers may not know exactly if they need chiropractor, massage, or acupuncture. So we haven't been able to make the service, the system change. And I don't know if Andrea and I've talked system change where there's just a one code for 408. They're still going to need prior authorizations for acupuncture code, for chiropractor code, and massage code. So in your care plan, if you're an organization that's providing all three, you're still going to have to say acupuncture, this is what the acupuncturist recommends, this is what the chiropractor recommends. And then that ideally is within 408. The challenge is what I'm hearing from a lot of providers who had enrolled but weren't getting members. Sometimes they would have members say, "Oh, we put in this care plan just with Shanda, and I can only receive services from them, even though like I have another provider and I would like to receive services from both providers." And so as long as yours are prior authorized, for acupuncture, there may be some coordination and some issues here, and we know that, but we're trying to be member directed and participant directed, so that the members, and so you are going to have to do a care plan based on what the provider recommends on acupuncture, chiropractor, and massage. But much like the care plan previously, it's still going to come down to the case manager and the member ultimately putting that on the prior authorization and sending you the prior authorization codes. Does that make sense?
I mean, kind of, not really. I mean, I guess because like some of my, sorry, but like, so I guess I don't see how that's different than what I do now. Because like right now, I usually try to max everybody out at their 408 units, but it has to be, divided between massage, chiropractic, and acupuncture. So I guess I don't understand how, if we're saying that we're just going to give somebody 408 units and they can figure out how they want to use it. They could use it all on acupuncture. They could use it all on massage, this and that. I don't understand that if I'm writing it out with only so many units for, massage, because chiropractic and acupuncture, I just don't understand how we're going to track that. Then if you're also saying that somebody could take their 408 units and they could go do some chiropractic at New Ability, and then they could come to Chanda for some chiropractic and this and that, how would, like between Chanda Center and New Ability, how are we going to track to make sure that somebody's not going over their units?
And that's where we have to put some thought into it. Thank you for bringing that to my attention. And I think that's, case managers, do you have any thoughts on that, or what's the thoughts for case managers? Because that's what we're trying to make the system easier.
I'm just thinking that it sounds like what you're trying to do is make it a little bit more like CLLI and how their part works, which was easy for Larimer County once upon a time, because all of the we only had one service provider. And so they managed all of the billing for art therapy, music therapy, grief therapy, and all those things, because they housed all of them at one spot. So I can see how now we don't have that anymore. So we just have to try and keep, I don't know. I think you kind of have to have one provider for each service. Like in the case manager and client are going to have to sort of realize that. I don't think you could go to chiropractor for two unless we're just constantly looking at the billing, which case managers don't have time to do. And say, oh, well, you only have 4 units left. So, which one you're going to use it at. So I don't know, but I see the dilemma, but it was nice when, CLI, we only had the one big provider. So I don't know how that's going to work.
Yeah. Well, yeah. And I think that's exactly that. We still have our big providers of New Ability and Shanda. We just have all of these other providers. And now we have, so I think that's what we're trying to gather is we took the unit cap away on Chanda's request, but I don't know if it's really going to make a difference ultimately for any of our pre-existing providers.
Yeah, and again, I just don't see how, if I'm still writing a care plan where I'm separating 408 units between 3 different modalities, how that's any different than what I'm already doing. I mean, if we're saying we're going to give somebody 408 units to use those as they, because right now somebody's capped at 204 for acupuncture massage, right? So if we're saying, okay, now the reason we're changing this to give somebody 408 units so that if they wanted to go over 204 for massage or go over 204 for acupuncture, they're allowed to, right? Because they have 408 units to use how they want. But if I'm still writing a care plan that has to break 408 units down per modality, I don't understand how that's different than what I'm doing now. And again, how we're trying to track that. I mean, ours right now, units are tracked via our EHR system. So we put in our EHR system how many units they have for each of the modalities. And then as they come in for appointments, our EHR counts it down. So that way we know that somebody isn't going to go over their units for billing Medicaid. And so that we know we'll still get paid. And again, I don't know how now we would track any of that in our system. And especially if someone's allowed to go to multiple places for the same modality. I mean, I don't see how you wrangle that count in.
Lisa?
2 thoughts. One on why we initially started this conversation about changing it, the cap, and then 2 about billing. One, I believe the reason we initially started this conversation is what was happening is someone would come in, they had on their PAR, they could get acupuncture and massage, but when they first signed up, they said they didn't want chiropractic. But they'd come in, had some sort of acute injury, and someone had I had recommended, hey, you could really use just maybe 2 or 3 chiro adjustments would be really good for you right now for this acute condition. And kind of, I think talking with Carrie about it is like, that can't happen in a timely manner. That's going to actually make any kind of change for this acute condition. And so we started talking and thinking, well, some people don't want to use all 3 services. Some people, want to just use anyhow. So I think that was the reason we ended up first bringing this to our attention when we were looking at changing the waiver. Secondly, without understanding at all how we do the Medicaid billing, I'm curious, is there like a central system where you put in the billing that would track the units so that, billing coming in from multiple clinics could be monitored?
Yeah, that can be tracked.
I think that's where you would need to monitor it, track it centrally, because that can't be on the providers.
Or the case managers.
Or the case manager, absolutely not. So that's my 2 cents.
Let's go in order. I think Dirk, you had a
Yeah, I had a thought about it as you guys were talking about it, and I'm completely new to this waiver since Developmental Pathways doesn't actually service this waiver just yet. But I don't know, as you guys were talking about it, like I've experienced this sort of situation before with other like IDD services like respite or day program, like people using multiple providers, and then you're kind of just tracking that as a case manager as a part of their IDT team and kind of just communicating with all the providers so they know exactly how much they have. So I've never done a care plan, so I'm not sure how all that looks like to actually monitor and figure all that out. But I thought it would seem similar to something like that, where the case manager is kind of helping both the individual and the provider to track exactly like, okay, we're using maybe 4 or 5 different clinics, and then here's the breakdown that we're doing with each particular one. I don't know if that's how it would work, but I think that's just the idea I had in my mind.
That's the vision. But I think people on the ground are saying that's not as easy as it sounds.
It's definitely difficult as you get more people involved. But I was just making sure I was on the right page with what everyone was thinking.
Carrie, I'm going to let Greg go first, and then we can circle back with you, Carrie. Greg.
Oh, Richard. Just wanted to introduce myself. I'm Richard Myers with Parmalized Health Consultant.
Great, and you're the massage therapist?
Yeah, I am. Yes.
Nice to meet you.
Meet you.
Great. Okay. Carrie.
So question then, so if I'm still writing like the care plan and I'm breaking down the 408 between the three modalities, or basically what we're saying though is like, I just want to make sure I'm understanding. So on my care plan, I'm still breaking it down the same way I'm doing now. But what you're saying is if ultimately the person still has 408 to use as they want. So even though my care plan is written at the cap of 204 for massage right now, you're saying that if they all ultimately went over 204 with their massage, that's okay. It's just they would have to obviously do less of another. So ultimately at the end of the 365 days, as long as they haven't gone over 408 units, the state doesn't care or will get paid for it. But
exactly. And I think this is much like in real life. I'm not real life, but in like without insurance, without Medicaid, a person can like decide they want to go. And the idea is like up with the care, how it was before, we would just do the 408. I think the nice thing is if a member now comes in and says, I want to do I want to see I want to do 300 with you and I want to do 108 with someone else, they can do that because that's what's going to like other providers like Greg, in Boulder or Greg are going to have an acupuncture. They're going to be able to put in 108, units. And they still may be able to go to Shanda. You just are they're so maybe easier, but there just may need to be a degree of communication from what the member wants from that.
So my other question is okay. So if there is this central hub that is counting down the units, so there's a central hub that all of our we've got a front desk and a scheduling person, so she's going to need to be able to access that along with our billing person to see when people call to make appointments or, switch appointments. Most of our participants are on recurring schedules, but so she can go to this central hub and see now is the 408 just going to be counted down from 408 and it's not going to be separated?
No, it's what's going to be out in so it'll be what's in the PAR. So still everything in Medicaid has to be prior authorized. And we have to be providing acupuncturist services need to be being provided by an acupuncturist, chiropractor services need to be being provided. So that, to get that to change would be just almost nearly impossible to have a unit just for CIH services. And that's not the direction we've been going. Looking at this, when I was looking at that, I was like, Andre and I had a conversation like this would be nice to be able to do this, but that would have needed to happen a long time ago, I think. And even then, I don't think it would have been possible, frankly.
So is the PAR in the Medicaid billing system still going to be divvied out by massage, chiropractic, and acupuncture?
Yep.
Okay.
So it's not going to look substantially different than what you're doing. We're just making the rules a little less.
I just don't see how then somebody's going to go, how will that then, if massage is still capped at 204.
None of them are capped at 204.
What?
There's no cap at 204. They can if someone wants to do 90-minute massages every week, they can now do that. You just have to put that as a prior authorization.
Yeah, but I mean, that's nobody knows ahead of time what's going to happen with their body. I mean, so how am I supposed to, I can't predict 9 months in advance that someone's going to have some kind of injury, like Lisa was saying, where all of a sudden it's like, oh, hey, they need some intensive chiropractic right now. And so they're going to go over, let's say in the beginning, when I write their care plan, they're like, I don't use chiropractic that much. I just want every other week. So that's 51 units. Let's say they sustain some kind of an injury where all of a sudden it's like, wow, some intensive chiropractic, 3 months into their PAR, intensive chiropractic, you need to come twice a week for chiropractic. So now that's going to put them over their 51 units. I still have to then turn around at that point and do exactly what I'm doing now, which is the painful process of, I now have to rewrite a care plan. I have to tell them you have to pull from your acupuncture units because the units got to come from somewhere. So now we need to steal units from acupuncture, so that I can rewrite your care plan so your PAR can get reapproved for more chiropractic units. I guess I just don't see how that's how we're doing anything different than.
And unfortunately, that's how the rules of Medicaid. I mean, those aren't like things we can change. Those are basic. I mean, maybe case managers have some thoughts on this. From my understanding, those are some of those basic Medicaid. The challenges with Medicaid is the prior authorization in general.
Yeah, so I'm basically now rewriting another care plan, guessing how many units I'm pulling from acupuncture to now add to chiropractic. And then, but what you're saying is now they're not capped at 204. So if somebody, so that's really the only difference, is if somebody all of a sudden needed more intensive massage therapy, I could now write, I'd have to rewrite their care plan saying, all right, I'll take 100 units from acupuncture and add it to your 100 units of massage. And now you get 304 units of massage. So we still have to rewrite care plans. The case managers are going to have to resubmit. We're going to have to get redone PARs. Yeah. Okay.
No,
I actually,
I know. We tried our best. I know.
honestly, causing a lot more work for the, between myself, obviously, and the case managers, because now they're not capped at a certain number and people are just going to be like, oh, no, all of a sudden I want more massage. And it's going to be a constant resending of new care plans and pulling the units from this modality to add units to that modality. It's going to be me submitting more care plans. The case managers having to, turn those back into the state, resending me a new PAR. But,
I mean, if that's the feedback, I mean, if there's enough things written, we can certainly keep in those units if needed be, and the care plan if need be. It's just those are our two options. Yep. Thanks, Lisa. Any thoughts on this from case managers? So
I would say I'm kind of on the fence. Well, I'm more leaning towards what Kelly had mentioned before in regards to CLLI, but yeah, this is a lot to think about. Yeah.
And this won't be changing. I mean, the unit thing we can change in July. The care plan was just a proposal. This won't be approved at the earliest until probably March of next year anyway. So there's room to have discussion about it. For
Okay.
sure.
Yeah, that would be nice.
And Casey, can I ask a quick question? So this is not my world, as you know, that how this all in the paperwork and the pre-approvals and all that stuff. But so the way I'm understanding this, a patient, the case manager, you have to define ahead of time how much massage, how much acupuncture, how much chiropractic. It's not just here's your bucket of whatever it is, 408 units. You have to get approval for each procedure. Oh, okay. That's kind of a nightmare. Yeah. Okay.
Yeah, so for case management, for our prior authorizations, you bill each line item is considered a service. So that's why it's separated.
So you don't just get your 408 units to do with what you would want
Don't,
and what the patient wants and what the provider wants. You've got to get approval every step of the way.
Yeah.
Gotcha.
Casey, is that an option to make it, they can all bill on the same line?
I got hit with that. Going through that. Actually talking with Andrea. There was actually that discussion if that could happen about 3 weeks ago. It's just come up as a possibility. It would be, knowing the system changes, it would be a huge system change.
Right.
But sure would make things easier, right? What is also happening is we did get funding for this ARPA funding to look at more participant directed model, kind of that where the member and the participant, not everything needs to be prior authorized to get to 408, then they can spend it as they want. That is where we're moving towards.
Mm-hmm.
But that we don't know if that will be able to launch with CFC or if it actually is just not going to make sense or it'll make sense. So, this is sort of kind of a temporary, moving towards this idea that we want to move towards participant directed within what the reality of what we have right now in place.
Yeah, I guess I think of another service with the non-medical transportation where we can just give them a bucket and say, use them as you want. Again, we only have one service provider that actually bills on that line. So then I guess my only concern is if they go see a chiropractor one day and if they lose track, right? And then someone's not getting paid would be my concern on the
Exactly.
provider side.
Yeah, and that's what I'm hearing. I'm thinking I can build out something from Cognos, hopefully, that we can, I mean, it's all being tracked, so we would just have to build a Tableau dashboard that was encrypted that people could look into if they needed
Right.
to. So
Yep.
that's kind of what I was thinking as Carrie was talking.
Okay.
Yeah, because we do, when it comes to non-medical transportation, we do have individuals that just splurge, the first
Yeah.
few months, and then they call you and they're like, hey, don't have anything. Well, we already told you were approved for this amount and you just went through it. So, yeah.
How
Right,
could
and
you
then
know?
they'll say the driver, or if they set up the ride, they say you don't have any rides, right?
Yes,
So I don't
that's right.
know if the provider, hey, I want to schedule this appointment with my massage therapist, and they check, like, yep, there's enough units, or nope, there's not. Call your case manager type thing.
Exactly. And is that all in non-medical transportation right now?
Yeah, there is a cap though. So the most they can have is, Alicia, correct me if I'm wrong, 208. I keep getting all that numbers
You're right.
wrong because
Yeah,
we're talking
that's
about
right.
208, 104, 408.
Yeah.
But yes, they cannot go over that. There is a cap. So say we're like, I don't think you're going to use very many rides. Let me give you 104, one round trip per week. And then they do go over that. I can add more. But if they get to 208 in less than their certification period, I cannot add more for that service.
Great. Thank you for bringing that to us. So yeah, it would be. You're right, Greg. Thank you. Let me check in with Janelle and see how non-medical transportation does, and let's see if we can mimic NMT for all of this tracking, so everyone can knows what's useful for left, because that's what's going to need to happen. If there's different providers, there's going to have to be a central place, and then work with case managers. So
right.
And there will be concern if they do use up all their units, they cannot go 30 days without services once we jump off the PHE. So if those are the only two services or whatever services they're using, that threatens that whole concern there too.
That's a great point, Alicia. Yeah. Okay.
Yeah, I was just going to say, I think that is a, great thing if we can start to move towards like what Kelly and Andrea were saying, if we can just figure out a way to track, if we can just have that lump bucket of 408 units and they can use the modalities as they want, and it just, whatever modality they use and gets billed, it gets ticked off. And I think that would be the
And our
idea.
timing may be our timing may be perfect now that you're saying this, because we have a system SCR, a system change is called an SCR. We have a SCR for those acupuncture roll-up codes. And what we may be able to do is just make a complementary integrative roll-up code. So if any of those are billed within the roll-up code, then they all just get put as a unit. So let me bring this.
Awesome.
I'm not promising anything, okay? Everyone can, there's just so many system things and things we don't know, and challenges within our system. So let me take this feedback back, and present some possibilities. And thanks, Lisa. I did not promise a thing. But I think this brainstorming has been super useful. I mean, at least we're one step there. I hear what you're saying with those 408 need to be on one line, and that if it's being done with non-medical, let's see if we can talk about doing a similar way. And the timing may be good on that. So fingers crossed. And maybe, hopefully it's not too late. Okay. Let's see. I think that's the big things on the agenda. We kind of covered the member engagement part with these understanding that members are kind of concerned, and we'll just keep working and trying to get these systems in place, and providers building those relationships with members, and case managers not having so much changes in their lives. Hopefully that'll change. We have 10 minutes if anyone have any more comments or feedback. I mean, this has all been transcribed and recorded, so all of this, we'll have everything that was said in notes. Yes, Lisa.
One additional thought, that just to kind of rally on the idea that New Ability had about hosting something for the case managers to see the work they're doing. If that is too much of a reach, an alternative to that would be hosting kind of an online platform like this for case managers to attend virtually with videos of, of course, the two big centers and maybe some client testimonials, to just get them the information in a way that might feel a little bit easier. No mute.
That's one of my thoughts. And really what I'm going to do is go by area. So Colorado Springs would highlight Greg and everyone Colorado Springs. And then we could do invite. So that was all right. But I really like the idea of in having providers video and then the invitation then from that to come and visit either of these places. And I think Amy Good, and when we spoke, we had a great meeting, and she also had the idea to remind case managers that, many of these providers carry insurance and have acupuncture or chiropractor in their insurance plans. And many of these providers, especially the ones I'm bringing on, have some of that option on there, or a community clinic. Like I know Greg doesn't take insurance numbers, but he has a community clinic where, local case managers can go and get treated there and use the community clinic, which I think is just such a good idea. And I think will really help case managers, one, relieve some of their nowhere to go and trust, and also relieve some of what's going in their lives. So I think that was such a great idea. Yeah. Thanks, Alicia. Yeah. So case managers here know you're going to be receiving those emails and highlighting those. Not only these are for members, but just remember most of these providers, some of these providers, at least also case managers can utilize some of these services too for their own health. Awesome, Greg. We'll make sure you're on that video, and I'm definitely get you connected up more with El Paso and Laura. Okay, Andre.
Do you have a list of care providers you still need, and where do you need them?
That would be a great question. I do in my head. I think that's something Shanda wanted from day one. Let me take, now that I kind of understand everything, I'm going to take that, Andre, and I will get that so people really know those areas where there's a need. We've talked about doing a heat map. ARPA's funding one, and we're hoping that heat map comes out soon. But if they don't have that heat map done, I'll make one specifically for CIH. Let me put that on my checklist.
I still run into an occasional therapist who seems interested when I tell him about the whole foundation and plan. So.
Yeah, and Lisa had that. So we do have now a really brief email. Is really written well, that if there is a member, we can send them an email with the I think you've seen it, the long brochure, so that they can kind of see if this is what they want to do. So let me make that a checklist of areas of need, and then make that email with vital information available for all the providers here or members here, so they can share that. We're close to be able to get that done. Let me make a checklist. I'm just calling it a heat map. Is that okay, Andre? Heat map of need areas, need for providers and members, and then email. That's what you're saying, right, Andre? That a short email template to send out when a non-enrolled provider is interested, or a member or case manager, really, or case manager knows of a provider. Great.
Exactly, yeah.
I'll make that a checklist. I will commit to getting that done by August. But I'm going to commit to getting that done beforehand, but it'll certainly done by our next meeting. And then we're going to host provider meetups with case management agencies before July 1, if possible. Virtual line units. Got those on the to-do list. Thank you all for your input as always. Any last thoughts? The only social media that's no, there is not a social media presence at this time. It's just the webpage. I think I've had discussions about doing that. We couldn't have a social media, but HICPUF has a way to manage the social media. And when we have there's this target of when we get providers across the state, we're going to launch a social media campaign probably in the fall. So yeah, I think that's it. Yeah, that's a possible. We could. Yeah, I know that. I think that's not a bad idea. Let's talk about that. I'll put that on. I think that's a. Anything else? Or are we're gonna use our exact hour and 15 minutes and have a great rest of the week. Yep, great, Alicia. All right, have a wonderful rest of the week and a great weekend, everyone. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Hey, Greg.
Hey, so
Did
I'd
that-
be happy to write up that the thing that I said for the AAC on the
Right.
process. I mean, this was super informative, but I mean, I remember when I was president, I mean, Shanda was just starting all this with 9,000 needles and all that. So
Yeah,
I know it's going to take a while.
right. But I'm excited, and I think how's your community clinic going?
It's starting to pick up, which is cool.
Yeah,
I mean, Douglas County is not really, prime area for this, but people are starting to realize, wow, because I mean, I've lost almost all my insurance patients because the insurance just quit paying. They just started denying everything. And that's not just me, that's dentists, that's all sorts of practitioners. So it just sucks. I mean, Cigna just got sued. So it's insane, that we have this. So and I'm glad that I can be part of this, and I think you're doing great work, and I know it's going to take time.
Yeah, and I think your community clinic, at least for a lot of these case managers,
Yeah.
if you didn't pick that up, these case managers are just stressed beyond belief right now, and they're our bread and butter of our social services.
Yeah,
like there's the people who connect with the people who need it most. So
Yep.
if we can just get them into your community clinic, I think that alone would just be.
Yeah,
awesome.
we have, and then what Richard and I were planning on is sort of tag teaming each member that would come in. That way we could, because that's how we do it here. I mean, we have a registered dietitian as well, so all three of us work together. We kind of come up with plans and
the gentleman,
balance it.
that's just awesome. Yeah, I think as we talked about before, the nutrition's so part of it.
Yep.
The gentleman I forwarded you, he's remarkable and definitely a leader in the community.
Uh-huh.
So I definitely will make sure. I think the two of you will just jive together. So
Nice.
I really hope.
I'm glad Richard was able to say hi.
I am too. It was great to meet him.
I feel so fortunate. I feel like I'm working with two professors that I have access to all the time.
Wow. He's going to be I'm so excited to see how this is just, he's a professor. He's a teacher himself, this guy.
Oh, nice.
And so, yeah, he's there's that buy-in, that working adult buy-in program. So he's a teacher professor in Colorado Springs
Uh-huh.
who had a car accident, something pretty young in his life.
Yeah.
And you know, so he's just a cool guy in general.
Cool.
So
Well,
hopefully that'll work out.
okay.
Laura Thompson, you have the emails of all the case managers, so
Yeah.
it's
Oh,
a process.
It looked like my email was wrong on the when you were pulling up stuff for Castle Rock. It should be phc@primalyzed.com.
Thank you for letting me know. Okay.
Yeah, I'll send you an email on that too.
Great.
So,
thank you.
all right. Well,
Correct that.
my patient just came in, so
Bye.
thank you so much.
Thank
Awesome.
you. All right. Talk to you soon.
All right. Take care. Bye-bye.